One thing that's clear from watching the initial stages of the 2020 presidential campaign is that the future of healthcare in this country is and will be an important theme. At least it's been so far in the Democratic presidential debates, which is what makes Timothy Faust's new book, Health Justice Now, particularly timely. It's a passionate and accessible look at healthcare in America, how we got to where we are, and why instituting a single-payer approach is the key to reforming the current troubled system. In making the case for single-payer healthcare, Tim argues that this model is sound and feasible, and if adopted in the United States, would lead to the greatest healthcare program in the world. Even if you don't agree with this approach, which does, of course, have its critics, it's certainly hard to refute Tim's portrayal of America's existing healthcare system as cruelly dysfunctional and hopelessly unjust. A few years ago, Tim spent time enrolling people in ACA programs in Florida, Georgia, and Texas, witnessing firsthand the shortcomings of the Affordable Care Act and the consequences of the Medicaid gap. Those experiences compelled him to research health policy more widely by driving around the country, which he did in 2017 and 2018, talking to people about their health care. The stories he gathered from thousands of conversations are reflected in his book. Tim has worked with groups such as the Democratic Socialists of America, dedicated to Medicaid expansion, and his writing has appeared on the news site Splinter and in the magazines Jacobin and Vice. In his regular day job, Tim works for a health insurance company, which has provided him with an inside view of the business. And as a fun side interest, he's also general manager of Party World Wrestling, which, right on cue, unbelievable, which is a group based in Austin that has developed a distinct mix of performance art, theater, and sport, featuring physical comedy and rather absurd storylines, all aimed at producing some of the craziest spectacles possible. Now, I'm not exactly sure what that has to do with healthcare, but Tim's publisher wanted to be sure that part of his resume was mentioned. Please join me in welcoming Timothy Faust.
Thank you very much. I appreciate that. Howdy, y'all. How y'all doing? Thank you, everybody, for coming out. I'm not really much of a writer, so having a book is buck wild to me. So thank you all for being here. Thank you, Politics and Prose, for hosting me. I see that I'm being recorded for posterity for the Politics and Prose YouTube channel, so I will be fossilized like a bug in the amber of historical record. And because that's happening, I want to take a quick moment to thank the two people to whom the book is dedicated, because now they can see it on TV. Whenever I have a thing where it's filmed, I say their names. It's important so I can make them watch it and get embarrassed or love me more. So first off, I want to thank my partner, Kelly Jo, for holding my hand literally every step of the way. This book took a very long time to write, and most of it sucked. I kind of heard people's worst days, worst stories, most crippling agonies over and over and over and over again, and if not for my partner, now fiance, I wouldn't have gotten it done. Secondly, I want to thank Ronnie James Dio, the god of heavy metal, lead singer of bands like Dio, Black Sabbath, Heaven and Hell, and Rainbow, for being the god of rock and inventing the horn sign. I don't think he's mentioned in many bookstore YouTube channels, so I wanted to make sure that he gets in there. Dio, thank you for making sure rock will never die. You are a god, and you're my rainbow in the dark. Yeah. You can just kind of say whatever you want if it's your book. Before I get into the talk, I want to share a good piece of news. It's going to be a lot of bummers for the next half an hour. Let's do something good first. This story comes to us from Quebec. Quebec is a place in Canada, I'm told, that has problematic but very brutal black metal and also a pretty low vaccination rate in the mid-70s. Now, generally speaking, if you want to have herd immunity, you got to have a 95% vaccination rate. So mid-70s is doing pretty bad. And so Quebec decided it needed to handle the problem. Now, folks who don't vaccinate their kids come in two flavors. You've got your hardline anti-vaxxers, folks that know that vaccines are chemtrails for your body and refuse explicitly to vaccinate their kids. And you've got a larger pool of the vaccine skeptical, vaccine curious, folks that Google, is vaccine good for my kid, and see a lot of misinformation on the internet, and therefore become, rightfully so I think, skeptical of the whole process. And those are the folks you can reach. But doctors have a hard time reaching these folks. Doctors have a very limited amount of time in a day. Doctors are impatient. Doctors can be brusque, possibly brusque, however that word is pronounced. And don't always, that dog's got fantastic timing. And doctors don't always make a connection with the patients in the ways they need to. So Quebec turned to somebody else. They hired 53 social workers and called them vaccination counselors and sent them out into the neonatal rooms. Someone gives birth, they go to the nice room to take care of the afterbirth or the post-birth process, and a social worker appears and says, hey, are you thinking of vaccinating your kid? Do you have any questions? Here's a chart, here's some more information. Here's a calm, patient, compassionate conversation about vaccination. And ultimately, it's your choice, and we respect your choice. What do you think happened? In the hospitals observed, vaccination rates went from 73% to 87%. Which is also buck wild. That's extremely good. That is the proverbial good shit. I want to be wrapped in this like a cloth and buried. And it's got the four components to me of what a good health policy story looks like. It's government-funded, compassionate labor that is done by social workers that achieves serious results. And it's a future that is actively denied us in America today. Because no private insurer, no Aetna, no Cigna, no Blue Cross, would ever spend the time investing in programs like these. They don't bear any of the risk or any of the responsibility. So all these things we see happening good up north cannot be ours, are actively being denied us. That gets me into my talk. Instead of talking right from the book and giving you 10 minutes on what Medicaid is and how it works, which is fascinating, maybe less fun, I want to talk to you about some of the themes within the book. It's not all funny. Most of it's not very funny or happy, but you probably already know that. There's a lot of bummers in this book, right? There's a lot of tears that line the page, but I try to find within it little glimmers of hope. Right? There's a vision in this book of a better world in which we can live free from the crippling fear of the betrayals of our own bodies, where we can stand together free and safe in our own flesh, and frankly, I really believe in it. I believe we have the tools and resources to build this freedom. We just got to demand it. We got to demand it in opposition to the world that we have now, a world that is not natural but artificial, that is created by people. And because it is created, it can be changed. But until it is changed, until we change it, ours is a birthright of continual exploitation. We are pumped for labor and drained of cash, and we suffer. And we are then punished for that suffering. We are punished for being hungry. We are punished for being sick. We are punished for being disabled. We are punished for being poor, punished for being black or being brown, for being queer, for being pregnant, for being unlucky. We're just punished for being. And at the core of all that suffering and all that punishment sit two little truths. In this world, sickness makes you poor, and poorness makes you sick. So if you permit me, for the next half an hour, I want to talk about that relationship and how it's expressed through our healthcare and health finance models. I want to talk about three things: what we have, what we want, and what lies beyond. I want to talk about the overwhelming and numbing brutality of for-profit healthcare. I want to talk about the relatively benign structural changes we demand instead. And then I want to talk about something bigger, which is a broader vision of that better world, the moral compulsion of health justice. That sound good? Yeah. Fantastic. Let's get into it. Let's have some fun with the fundamentals. That's the last laugh for a while. One, nobody can afford to pay their medical costs by themselves. Medical care is extremely expensive, but generally speaking, not a lot of people need medical care all at once. 50% of medical costs come from 5% of the population, a population which someday you will join, right? We're all temporarily able-bodied. Eventually, your day of tragedy comes, and when it does, the medical costs will be enough to bury you. So we have the concept of insurance, right? Insurers pool together money from a lot of people to pay off medical costs for those who need it. And so the larger this pool of people, the wider it can spread costs and the lower the per-person costs or per-person risk. In the US, we delegate the business of insurance to private insurance companies. Insurance companies charge us monthly premiums to build their risk pool. And like any company, insurance companies' jobs are to make money. And so here's where it gets dumb. If people use their insurance plans, the insurer loses money. If an insurer has too many people who use their insurance plans when they get sick, or too few healthy people, or too many sick people, just one person with hemophilia can cost up to $1 million a year to treat, the insurance company's per-person costs really increase. And so to compensate, it increases premiums. But when premiums go up, customers who can't afford them drop out. But sick people can't afford to drop out because being sick and uninsured at the same time is a death sentence. So you have a customer base that is even more expensive per person, leading once again to higher costs, higher premiums, leading once again to an even sicker, more expensive population. It's this big, stupid Ouroboros of misery. Thus, an insurer wants as uneventful, as boring, as a non-active a risk pool as possible, or it wants to find ways to kick out sick customers or coerce them into leaving. Maybe it drops coverage for the drugs sick people need. Maybe it cuts off access to the doctors who treat the sickest patients. Because insurance companies don't lose money when you get sick. Insurance companies lose money when you get sick and then use your insurance plan. And frankly, there's nothing they can do about it, even if they wanted to. Because if insurance companies were to offer the care people needed where they need it, or if they were to offer it at rates sick people could afford, sick people would then buy those insurance plans and use those insurance plans, and the insurance companies would lose money. And that's no way to run a business. You know, at some point along the line, I wonder what's even the point of blaming them. Blaming an insurance company for hurting sick people in the expense of profit is like blaming a rabid dog for biting, or blaming a scorpion for stinging. This is just what companies do. And that's why healthcare doesn't belong in the hands of companies, because they just can't do the right thing. Instead, they've turned our bodies and our health into commodities. This commodification of healthcare reduces health to a financial transaction or an investment vehicle instead of a connection or relationship between a person and their body and their doctors and their community. That's perverted. We've just mistaken the profit motives of corporations for healthcare. And the people who profit from the commodification have decided to shackle the well-being of children to whether or not their parents were lucky enough to have employment or have a benevolent employer. And you know why they get away with it? Because they spend $50 million a year on lobbying, and until recently, nobody had the guts to do anything about it. So that's one side of the coin. But it gets worse. It's too early in the talk for things not to get worse, because the costs of healthcare keep increasing. Most of these cost increases occur because hospital CEOs, pharmaceutical companies, close personal friend Martin Shkreli keep finding more and more ways to charge money for the same services or rack up fees for other services, and no private insurer can really stop them. Here's how that shakes out. In the US, the average inpatient procedure costs 40% more than the same procedure performed in France. Or consider MRIs. Y'all know MRIs? MRI machines are just big fancy tubes that print money. And in the US, an MRI scan costs 5 times more than the literal same machine doing the literal same scan when scanned in Australia. Or worst of all, think of the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, the kind of familiar, intimate healthcare you get from your family doc or GP. It's high volume, it's low margin, and generally, being a family doctor isn't super profitable. But now, conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So if you're a hospital CEO, it makes a hell of a lot more sense to push folks into inpatient care instead of wasting your time and minimizing your profit, letting them get cheap primary care outside the hospital. Or it makes even more sense to buy up all the cheap primary care clinics and either close them down or use them to charge hospital rates, which is what they do. What's that mean? That means 58 million Americans have no access to primary care whatsoever. So as you can see, these are the two fundamental but opposing truths in American health. One, if you're an insurance company, it's just not profitable to insure people who are sick. 2, if you're a big provider, like a hospital, it is extremely profitable to charge sick people as much as possible, as late as possible. We've built upon these jagged rocks the loathsome church of American health, in which the question of who gets to receive health care and when, or rather, whose suffering matters, is rationed by profitability. Now, this whole scenario scares the bejesus out of everybody involved, particularly insurers. Insurers are interested in finding ways to avoid paying these rising costs. Often that means they just don't pay for claims they don't want to pay. That's probably happened to you. It's certainly happened to someone that you love. But that's not enough by itself to claw these costs down. So we all got together, everybody in America, back in the 1970s, and invented the idea of consumer-driven healthcare. That's the idea that you should make consumers, which is just a libertarian way of saying people, pay more for the costs of their own healthcare. That's why your deductibles and your co-pays and your cost shares go up year after year after year, to make you put more of your own skin in the game. We've decided to punish people with healthcare costs they can't afford under the guise of making healthcare a matter of personal responsibility, also that healthcare CEOs and their friends can bring home millions and millions of dollars a year. But you know what's worse than that? It doesn't even work. Well, I mean, it works for insurance companies when to pay out fewer claims, but it doesn't work for people. Because people who are forced to pay for healthcare costs they can't afford just don't get healthcare. They don't seek primary care, preventive care. Because we demand they bear the burden of costs they cannot afford, they watch their bodies turn to time bombs until they have a heart attack at their jobs. But at the end of the day, costs keep increasing, quality of care stagnates for the most vulnerable among us, and 31 million people are still uninsured. The American model of health has failed. And there are consequences for this failure. Because among so-called developed countries, it is America that is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black. Black infants die at twice the rate of white infants. America is the most dangerous place to be pregnant, with the highest maternal mortality rate of any developed country, of which 60% are entirely clinically preventable. America is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. Last year, life expectancy at birth fell by 1/10 of a year, and across the 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you examine all this data. When you look at all this data more closely, you understand all this danger only exists if you're poor. Because rich people are exempted. Rich people have exempted themselves from all these problems. Men born in the wealthiest fifth of Americans get to live 15 years longer than men born in the poorest fifth. Among women, that gap is 10 years. This is war. This is the terrible secret of American healthcare. This is the fundamental American illness. They are killing us and robbing our corpses to foot the bill. And so this big, stupid, multi-payer, profit-driven Rube Goldberg machine of American health is failing us today, and left unchecked, it will collapse tomorrow. That is incontrovertible. It will collapse. So we demand something different. We demand a federal, universal, single payer. Single payer is a pretty simple concept. It took me 10 minutes to explain private insurance to you. I can explain single payer in one sentence. Instead of having a bunch of insurers with fragmented customer bases, each seeking to avoid taking care of unprofitable sick people, we pool together all the money we currently spend on healthcare to create one publicly owned, publicly funded insurer, a single payer, with a mandate to cover in full all care for all people. That's one long sentence, but legally that's one sentence. Now, this phrase, all care for all people, is crucial. We don't want Medicare as it exists today. Medicare has private carve-outs, Medicare has cost-sharing, premiums, and deductibles. No, we want an improved Medicare that guarantees comprehensive coverage, medical, dental, mental, vision, and long-term care for all people in America, including non-citizens, that is free to use. Everyone benefits when accessing care is easy. Delivering care, being a doctor, being a nurse, being a home health worker, that's complicated. The body is a huge bag of unknowable goo, and relieving its misery is a difficult process. But paying for it isn't. Paying for it's pretty simple. People ask, well, how can we pay for this? We're already paying for it. We're just being forced to spend our money really, really stupidly. Practically every healthcare transaction in the US is partially subsidized by public money. By some measures, American public money pays for 2/3 of all healthcare costs in the US. Little less than half of that 2/3 is direct Medicare, Medicaid, or VA spending. Other half is government subsidies to private companies. The remaining third is out-of-pocket costs, your premiums, deductibles, and copays, a kind of tax, private tax you pay to your insurance company. And frankly, you're getting gouged. America is already spending the money required to fund single payer. One study claims that the single payer plans before Congress would cost 10% less than what we're currently spending now. 10% to cover all people in full. The insurance industry is just incompetent and unable to pay its fair share, so it shovels the costs back upon you. And so the goal is to liberate all people from medical costs, to cut out this thorny underbrush of middlemen and reallocate this spending to take care of everybody long term. Part of the reason costs are so high is because private insurers, with their little small customer bases, just can't negotiate with big hospitals. Insurers need hospitals much more than hospitals need insurers. But right now, Medicare negotiates on behalf of 44 million people, so they get to set better prices. And so scale that idea up. Because the single payer, because Medicare for All, negotiates on behalf of 330 million people, it can basically set fair prices for care while compensating providers justly. So these wildly inflated costs get their balloons popped and brought back down to earth, and then we're playing on an even field. But even before that happens, we free up all the money associated with administrative costs and marketing costs and profit seeking in the private insurance market. This optimization, this great innovation, opens up, in a conservative estimate, an additional $370 billion a year. 370 bundo, that's a big chunk of change. What do you do with it? You use it to improve everybody's standard of living. You build or reopen primary care clinics in rural areas. You fund community health centers in poor neighborhoods. And most importantly, you return the money to the people who do the work. Take, for example, home health aides. Y'all know home health aides? Folks can receive care in the hospital, but again, that's $2,000 a night. Most folks can't afford that. For a lot of people, they can receive the same standard of care, getting their meds changed, help getting in and out of bed, at home. And for most folks, home is a nicer place to be. Home is where your dog lives, home is where the internet lives, home is where the TV has all your channels pre-programmed in it. It's fantastic. And home health costs only $120 on average per visit. Right? So it's more humane care and we save money. Everybody benefits. Well, everybody except for home health aides themselves. Because for this humane and essential service, the 1.2 million home health aides in America are paid only $11 an hour. So we can allocate this money to do what the private market refuses to do: pay fair wages for essential care that helps everyone. Think about it, right? Who makes a real difference in health outcomes? Is it luxury hospital suites? Is it multimillionaire surgeons? Is it $40,000 data packages for nerds to look at? No, these are just the folks that get to bill the most. What makes a real difference is extra clinical care. It's compassionate labor. It's social workers, patient advocates, vaccine counselors, nurses. These are the folks chronically unrecognized and undervalued, and also the primary drivers of population health, people who make a difference. These are pretty basic ideas. These are pretty simple demands. We understand the social forces that make people healthy, and we understand the structural ones that make people sick. But in the multi-payer private model, nobody's investing in long-term health. Nobody's investing in population health. Nobody is investing in compassionate labor or paying those workers fairly, and they never will. Because right now, your private insurer only bears the costs of you receiving care while they're insuring you. Because you're gonna change insurers in the future, and one day, God permitting, go on Medicare, they feel no pressure to provide you with care that keeps you healthy or makes you healthier in the future. Let me put it another way. You know that if you're at home and the window breaks, the weather gets in. And if the weather gets in, the rain gets in, the heat gets in, the snow gets in, you might get sick. And if you get sick, or if your kid gets sick, you gotta go to the doctor. But if the local clinic was shut down, or it's booked solid, you gotta go to the hospital. And if the hospital's far away, and you don't have a car, you gotta find a ride or take the bus. And if you got to take the bus, you got to spend all day dealing with the bus system. And if you got to spend all day dealing with the bus, you can't go to work. And if you can't go to work, you don't get paid. And if you don't get paid, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the hospital. The answer begins with giving people what they need to fix the goddamn windows. But there are no private actors in the American model who will consider responsibility for fixing these problems on their own. The only innovations of the private insurance industry are ones created to solve the problems caused by the private insurance industry. They are incapable of addressing the real and foundational problems of health, of fixing the broken windows, of reopening the 18 rural hospitals that have closed in Texas in the past 5 years, of repairing the PVC septic pipes of South Carolina that have ruptured and brought hookworm back to the state, in the exact same way that a billionaire is incapable of shrinking income inequality, or a cop is incapable of lessening the prison industrial complex. They cannot fix this injustice because they've been constructed by that injustice. They cannot solve these problems because they existentially cannot conceive of them as problems in the first place. But we can, and we do. And so it makes perfect sense that the same actor who suffers when people don't get care should be the actor who pays for that care in the first place. Because once that federal actor, once that single payer bears the costs of providing care and the costs of what happens when care is not provided, once we force it to confront the rampant suffering of all its people, it can finally be used as a tool for realizing health justice. If your people are suffering because they don't have a place to live, or where they live is unsafe, it's full of water, it's full of mold, it's flammable, then housing is healthcare, and you build social housing to bring healthcare costs down. If your people are suffering because they don't have access to healthy food to eat, so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare, and you provide them with affordable or free food options to bring healthcare costs down. If your people are suffering because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare, and you build full-cycle addiction treatment programs to bring healthcare costs down. Because single payer is wonderful, but single payer is not the goal. Single payer is only the tool. Health justice is the goal. And when we fight for health justice, we all fight side by side because economic justice is health justice. Environmental justice is health justice. Reproductive justice for those who don't want to reproduce and those who do is health justice. And justice for Black lives, justice for brown lives, justice for trans lives, justice for lives of immigrants, justice for people in prison, and the well-being of all people, regardless of age, gender, race, or creed, that is health justice. We have inherited a world in which your permission to receive health care, your permission to be safe in your own goddamn body, is dependent upon how much a corporation can extract profit from you. And thus, we have permitted in our country utter desolation. And I want to talk about that desolation now. Over the course of researching this book, I took to the road. Every morning I'd wake up, eat a banana, drive 6 hours in my 2002 Honda CR-V, give a speech, and then talk to people. People who would tell me just the worst things that have happened to them. I kind of became a library of human misery, and what an honor it is to be that library. So I want to share with you 3 stories, one long, one short, and one medium, to contextualize the fight for healthcare and the movement for health justice. First story takes place in Houston. One thing I haven't really discussed much is mental health, and you can't talk about mental health in Houston without talking about Harris County Jail, and how it's the largest provider, quote unquote, of mental health services in all of Texas. Which is a fine observation, but doesn't really do anything to investigate the relationship between mental health and prison. Let's talk about that. In Houston, people who are arrested and suspected of having mental health issues are held in these dark, dank, dungeon-esque cells in the Harris County Courthouse. They're hidden away. You wouldn't know these cells existed unless you were looking for them. So if you're a person with mental illness who's already been locked up for several days for things like trespassing or disorderly conduct, what do? You haven't had your medication or any care while you've been locked up, so you got 2 choices, right? One is plead guilty, and you might get out in time served. 2 is fight it, and you're looking at more time locked up without your meds. And this is if you're lucky enough to pass as functioning normally. If you're in the middle of a serious mental health episode, things get worse. Then you're held for up to 30 days until the county gives you a session with a psychiatrist. People are held in the hospital wing of the prison or the prison wing of the hospital. There's this concept of the prison to hospital pipeline, which comes up when you discuss mental illness in jail, but it's not a pipeline. Pipelines go in one direction. It's more like a big pinball machine. These giant invisible flippers bounce people around from jail to hospital and hospital to jail, jail to hospital, hospital to jail, and at some point there's no functional difference between the two. We refuse to care for people, and so they become sick. We make them sick. And if you're the wrong kind of sick, or if you're the wrong kind of person, we delegate your care to private prisons. It's technically not a crime to be poor. It's technically not a crime to be sick. It's technically not a crime to be black or brown, but once you fall into the intersections, the rules change on you. If you're a poor single mother of color, for example, you have virtually no right to privacy. If you're in Section 8 housing, every month a state agent comes to your apartment and counts the shoes on your shoe rack. If they find too many shoes, or if you're a single mother and they find a man's shoes, you can lose your benefits. If you're disabled and you're on Medicaid, twice a month a nurse comes to your house to check to see if you're still disabled or if you've been faking it the entire time. If you're a Medicaid recipient in a work requirement state, every month you gotta wait in line for hours at an understaffed office to prove that you're employed. And these processes drive people into the hospital or into the streets or into jail. So long as we use prison to hide those who are undesirable, healthcare and prison are inseparable. So while the idea that prisons are the largest providers of mental health care in the US is a well-intentioned and technically correct point, it's wrong. Because no prisoner will ever receive the care, support, or resources they need to handle whatever's messing with them. And no prisoner will ever be spared from the return trip once they get out and remain sick and get arrested again. Because prisons are not hospitals. They are warehouses for the mentally ill. They are storage units for the unwanted. That's Houston. Another story I want to tell is of birth and death in Memphis, Tennessee. At the turn of the century in Memphis, 20 black children died for every 1,000 live births. 20 black children died for every 1,000 live births. That is an incomprehensible statistic. That is seen nowhere else, anywhere in the first or second world. That is brutal. Why did they die? Because Memphis is home to 2 nuclear waste disposal facilities which are pushed up against black neighborhoods. But it keeps going. Where do poor babies go when they die? They go to Babyland, which is a corner of the Memphis Public Cemetery. They are put to rest in cramped rows beneath the earth in unmarked graves a block and a half from a Walmart. Or at least they were until recently. Because in 2014, Babyland filled up. Poor black children in Memphis die in such volume. America is killing the poor black children of Memphis by poisoning their mothers and poisoning their homes so effectively that we have run out of room to bury the bodies. And finally, I want to talk about Scott County. You might know Scott County, Indiana, is one of the few places in the US with a new population epidemic of HIV/AIDS. We understand why. 1, pharma companies invent tamper-resistant pills which can't be crushed and snorted, which does nothing to stop misuse, but is very profitable. If you're a person battling addiction, not being able to snort doesn't keep you from using, you just turn to heroin or turn to fentanyl. 2, then Governor Mike Pence shut down needle exchange programs in the state. Needle drugs are illegal, and so therefore they're for criminals, and why should we spend money on criminal health care? 3, Indiana gutted, shut down, or cut funding to community clinics and places like Planned Parenthood. And so here's the breaks. If you're a person in Indiana battling opioid use disorder, tamper-resistant pills mean you turn to needles. Except now you can't find a clean needle because the exchange is shut down, and the other clinics you might have gone to are unavailable as well. And so what happens is predictable, right? More folks get HIV/AIDS and Hep C. But that's not where the story ends. These people have families. They have kids. They have communities. Now they got HIV/AIDS or Hep, or they're in jail, and their families miss them. They've been left behind. Indiana also has a very low property tax cap, which limits school funding, and has a robust school voucher program. So better off families who didn't want their kids to attend school with the children of the left behind sent their kids and their tax dollars elsewhere. So Scott County schools got less and less money and more kids with families going through the shit. And that means fewer teachers, less food, no mental health, no guidance counseling programs. I spoke with a man who said you could spot a kid going through hell from a mile away. A kid without a parent in the system, a kid without support, a child just unmoored in the world, but there was nothing they could do to help. There was no funding. There was no funding for breakfast, no funding for therapy, no funding for daycare. There just weren't any resources for the children of the left behind. And so Scott County saw an increase in child suicides. All these things have causes. And all these causes are cyclical. They have happened forever. They will continue to happen so long as we tolerate the idea that the body is a commodity. I say these awful things not to pornographize suffering, but because these are the stakes of the fight for health justice. And so I want to be explicit. Insurance is not enough. Our goal is not simply insurance, but emancipation. We must put the people who have been most harmed at the front of the line. We must walk together every goddamn step of the way. We must never compromise until all have been liberated. Why is it that some have adequate housing and others do not? Why is it that some have adequate food, adequate income, adequate safety and dignity and humanity while others do not? Why is it that some live freely while others are compelled to fear their own bodies? Our health is apportioned to us along the lines of structural poverty and structural racism. Our American body has been poisoned by the wicked snakes of racial and economic and patriarchal domination. And so when we attack, we must aim for the heart, the beating heart of capitalist exploitation. And these are problems private insurance cannot fix, and will not fix, and in some cases has caused. These are problems which can only be addressed with the full force of all America's people, our bodies together forming the shape of our government, armed with a single-payer healthcare system. Single-payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. Now, there's good news. We know what works. We stand on the shoulders of hundreds of thousands of nurses, of tens of thousands of doctors, of tens of thousands of med students, and the legacy of grassroots movements like ADAPT and ACT UP, which fought against impossible odds and won and won and won. In San Antonio, the movement for paid sick leave turned out 144,000 people, making it the largest popular movement in years, if not decades, in that city. In Idaho, 3 friends bought a green camper van and drove it around the state to build a movement to expand Medicaid. And that movement won 61% of the vote in 2018. There was no blue wave in Idaho. The Dem nominee for governor lost by 22 points. It was a massive mobilization. And through these massive mobilizations, and only through these massive mobilizations, this is a fight we will win. This is not a radical proposition among the folks it affects. People generally like single payer. They like it more the more they learn about it. We are simply discussing a basic principle of fairness. And so to close, I want to offer you my profession of faith. I believe, beyond any doubt, that single payer is demonstrably sound and eminently feasible. I believe a properly ambitious and well-structured single-payer program will do more than any other American program of this generation to soothe the burns, to resuscitate the spirit, to nourish the moral will of the American people. I believe it will loosen the loathsome manacles of American health finance, which is an exploitative institution which profits by plundering from us our own bodily autonomy. I believe this nation owes its people, whose labor has created its rich banquet, the safety and agency of healthcare. I believe this healthcare is greater in scope than that which happens on an operating table. I believe that housing and food and income and more, the components of basic human dignity, are healthcare. And I believe our work is that of striving towards justice for all people. And I therefore believe I have to believe that single-payer healthcare is our moral imperative. Single-payer is our tool. Single-payer is our weapon. Single-payer is our first step. But single-payer on its own is not the goal. I have seen such naked suffering inflicted in my American name. I have seen families ripped apart by the unrepentant, unyielding bloodlust of capitalism. I have seen people torn limb from limb in the service of extracting profit, and this is intolerable to me. And so I say, enough. Not in my name may this America persist. May we root ourselves not in fear, but in love. Love for those who suffer around us. And from that love, may we cultivate the fury by which this cruel machine will be destroyed. My friends, single payer is moral. Single payer is necessary. And single payer is, I swear to you, single payer is achievable. Solidarity now, solidarity forever.
If you have any questions for Tim, we've got one standing mic over here.
Okay. I'm over here.
Yes, ma'am.
I'm a primary care physician, and everything you said is true. I wouldn't put it quite that way, but we need people like you, but we also need people like me to work out the details. My name is Dr. Caroline Poplin. I write about this. You can Google me if you want. What I'm concerned about now is watching what has happened is the Affordable Care Act construct is all about using the market to get health care. It doesn't work. It's too expensive. We're spending money for things that have nothing to do with health care. But the single payer plan that's in Congress has no analysis to go with it. It's the Physicians for National Health program that's been around since 1986. Steffi Woolhandler and David Himmelfarb. They're both doctors. They're married, and it's their plan. It requires that everybody give up their employer-sponsored health care immediately, or within 2 years, or within 4 years. That's a requirement. There's no reason for that to be so. The employer-sponsored healthcare, it doesn't work well, but it works well enough so that we can work on Medicare, figure out how to finance it with it'll be financed like Social Security. It's social insurance, just like Social Security. But there are no think tanks working on it. There's nobody to do the analysis that needs to underpin it. It's not exciting work. It's not what you're talking about. It's very boring, but it needs to be done. And we need to get rid of the problem of forcing everyone off their employer-sponsored insurance, not off their ACA plans. That's nonsense. But employer-sponsored insurance, because that's going to stop it. That's what everyone is scared about. That's what the Democratic debates were all about. We can't force people to give up their insurance for something they don't know what it is. The question is, how do you feel about that?
That's a great question because I feel very strongly about that. First off, thank you for your comments. Secondly, there are two parts to that question. The thing preceding the question, which one is about there are no think tanks on single payer, and two
Right.
is employer-sponsored insurance. One, on think tanks, if you build it, they will come. This is a marginalized movement.
Yes, you're right about that.
Once you have a viable movement for it, once you have legislative force, think tanks will analyze it. And I welcome their analysis. Two, employer-sponsored insurance is not working well. Average deductibles hitting $6,000 for people.
I agree. But it's working well for people who aren't sick. And
That's
why do we
everybody.
have to give it up?
Because it's doing a lot of bad things. And also, it weakens the risk pool. A universal risk pool is the essential component of single payer, thus the term single payer. People don't like their employer insurance. People love being insured, but no one loves their insurance company. People aren't going to bat for Aetna, Cigna, Blue Cross. People are going to bat for insurance in the first place. Because only thing worse than employer insurance is not being insured. I mean, the ACA plans, but there's a gradation there of kinds of insurance. And when you tell that to, like, right now you see like the single payer for all polls at this level, which is like what, 53? It's 84
Right.
among Dems. And then you say you'll be off your employer plan and it dips. And you say again,
Right.
but you'll still have insurance and it goes back up. Like there's an effect there. The more people learn about single payer, the more they like it. I disagree with the idea. Like, you can't maintain employer insurance in parallel with a single payer. That makes it no longer a single payer. That makes it then you have a two-tier approach, which has failed in many countries across
We
the
have
globe.
single payer and employer sponsored insurance
That's not
right
single
now.
payer. That's not, yeah, and it's
Medicare is.
Medicare is not single payer.
It used to be.
Not really, because it doesn't have universal risk pool. I hate to argue with you because you came all this way out to listen to my book talk, and I really appreciate that. But Medicare is not a single payer program. It's a large payer program. It's a big payer program. I'd agree with that. It's also a pretty, like, it does a lot for a lot of people, but it's been carved out. You have Medicare Advantage programs. You got private privatization in there. You have
It has to be fixed.
You have deductibles and copays. If you're going to go to all the work to fix Medicare, why not fix Medicare and make it a Medicare for all program? Like, all these things.
Can we go to the next?
Excuse me?
Next question.
Thank you very much, ma'am. Doctor.
Timothy, your passion for this subject is just extraordinary. You are a beautiful human being. My question is about single payer, and where does that leave the Blue Crosses of the world, the Aetnas of the world, and aren't they going to hire all of their lobbyists to fight single payer?
100%, and they already are. And they'll get you can kind of measure how good the movement's going by how much money they spend on lobbying. Right now they're at 50 mil a year plus 70 from pharma, and that'll go up in the next couple of years. The ACA happened because insurance companies admitted that they were doing a very bad job and cut some compromises to stay profitable and subsidized by federal money. What happens to Blue Cross and Aetna and Cigna? Frankly, I don't care. But I do care what happens to their workers, because every labor is labor. I mean, I work at an insurance company right now. Obviously, the things that I say don't reflect them or vice versa. But there's a lot of there's two components: the companies and the people who work there, right? We can bifurcate the two and take them both in turn. The companies, I don't give a hoot. We can nationalize them, buy them out. Frankly, I think it's worth the cost to pay 1/3 of our annual NHE, national health expenditures, to just line their pockets to buy their infrastructure and let them go home. Like, I'm okay with that. Fine. Everyone's relatively happy. It doesn't cost that much long term. That amortizes well. Cool. Or we can just squeeze them out of existence by having a single payer there and, I don't know, make it not legal to sell insurance. And they can sell supplementary insurance, which covers things for rich folks, which they'll do anyway. So I am happy to get rid of private insurance with whatever tactic is the one that works. I think bribing them might be the reasonable one.
Do you think it'll happen?
Pardon?
Do you think it'll happen?
It's not that expensive to do so. In 2010, I believe, the gross valuation of the insurance industry was $500 billion, which is a lot of money. Sorry, $900 billion, more than under $1 trillion. Which is a lot of money. That's less than 1/3 of what we spend on healthcare costs in a given year. So it's a big upfront cost, but, like, is it worth it to avoid long-term conflict? Maybe. I don't know. I'm also, again, very happy to just say, no, you're illegal now, go away, which we can do. We can make it illegal to sell insurance plans. They'll fight that. I think there's a political calculus to be made there, and luckily, I'm not the one who has to make that choice. Then there's the laborers. People who work at insurance companies. And theirs, I think, is a much more interesting and joyful future. A single payer is forced to, if it wants to maintain long-term costs, invest in new kinds of jobs, both new jobs and new kinds of jobs. There's this whole universe of labor out there that we're not using, that we're not tapping into, that we need to have to bring down costs and improve outcomes. I think vaccination counselors are an example of that, right? That's a new job the government paid for to bring up population health outcomes. Let me give you an example of and these all end up being social worker jobs, compassionate labor jobs, home health nurse, social worker. Let me give you an example of a kind of job that I think is really fascinating, and like a new model that no insurance company's ever touched, but only single payer, only Medicaid, and I think our single payer model would touch. It's called a medical legal partnership. It was pioneered in Boston, where occasionally good things happen. And it's a clinic it's a Medicaid clinic with two wings. A patient comes in, this is a real anecdote, and brings their 4-year-old kid and says, my kid has real bad asthma. And the person behind the desk is a social worker, a person hired by Medicaid to work at this clinic. And they say, okay, That's medical. Let's get you medical care. And brings the patient and the kid, I guess the patient and the parent, down one door to the doctor or the nurse. And the nurse says, that's asthma. Here's some albuterol or whatever inhaler you want to use. Fantastic. But the social worker knows that asthma in kids is caused by home conditions. So the social worker says, well, what's your home like? And the patient says, I live in the projects. There's mold in the walls. There's water in the ceiling. I can't do anything about it. Well, it turns out, in theory, you can. You have civil protections against things that make you sick, but you only have access to those protections if you can hire a lawyer or the time, literacy, and fluency to be your own lawyer, which nobody can do. So the rich have their own separate stratum of legal protections they have. So the social worker brings the patient down to wing number 2, where there's a lawyer or a paralegal, or maybe my fiance, ready to. My fiance did this. Sorry, that sounded creepier than it was supposed to be. In the anecdote, this was my fiance. Is waiting, ready to draft a letter to the landlord or the person running the property, saying, "Hey, we know there's mold in the ceiling. Fix this in 30 days, or we sue." And what do you think happened? It was fixed. You have this whole. So this person's job, the social worker's job, was to take a person who was sick and discover the universe of things to which they were entitled, to give them the protections they deserve and are guaranteed by the U.S. Right now, if you work at an insurance company, your job is probably either on the phone or working as a nurse. And either you're arguing with insurance companies or you're telling your customers the minimum amount of care you're required to provide them, right? You look at their universe of care and kind of slash it down. See how small you can make that patient before they fit into the window you're willing to cover. But those folks have important skills. And here, in the medical legal partnership, is a chance to give them an opportunity to give them a chance to use those skills to help their communities instead of harm them. And these are the kinds of jobs we gotta hire for. And here's a bunch of people who have those skills, the soft skills of doing compassion labor, of talking to people. And so I think a single payer that has a robust job training program, which both Jaya Pauls and Sanders' bill has, is forced to really explore, this is the frontier we're on. What are the cool jobs we can and must build to keep our people healthy? So I think they do pretty good, and we do pretty good as a result. Oh, thank you.
Hi, thank you. I've learned a lot already tonight. I'm from Boston, but I won't take that last comment personally. So the United States essentially already has a single payer in the VA system. And so I'm wondering if there are any lessons, good or bad, that we can take from the VA in constructing this new single payer system.
Yes, the big one is don't underfund your thing. The VA actively gets its budget slashed every year, right? And then at the same time, we have a new wave of folks who are exposed to Agent Orange or aging Vietnam vets who are getting sicker and sicker and sicker. And so you have a higher sick population and a lower and lower budget to deal with them, which is bad. Mm-hmm. I think that's our big takeaway. It's the neoconservative model of austerity, right? You take a good program, you starve it, it does bad, you punish it for being bad by starving more of it over and over and over again. That's the VA example. We just don't spend enough money on VA care, and as a result, it sometimes does a bad job. Sometimes it does a great job. There's a lot of folks getting great VA care, but a lot of folks are deprioritized or lower on the waiting list, or are newly sick and they're not getting the care they need. So I think that's the example: is you got to fund this thing and fight to fund this thing, and not let it become a political football. If you want to see the VA, but even worse, you can look at the IHS, Indian Health Service. The IHS has been just fucking gutted. It was never funded well to begin with, but they can't afford to pay to keep their hospitals running, especially in rural or remote areas. They have a block grant, which they're given a fixed quantity of money for a given time period, and there's they have to pay out of pocket basically to hire specialists to travel into their hospitals. They've been just totally destroyed because we're racist, and because we have terrorized Native American people for very long, devaluing them. But that's another example of the same kind of model we apply to the VA. IHS does a bad job, so we cut its funding. Blah blah blah. Answer your question?
Yeah, thank you.
Tim, we have time for one more question.
Great.
So, first of all, congrats on getting engaged.
Thank you.
Second of all, I know that you say that it would be very difficult or to get a state level single payer program off the ground, especially if there were a recession. So, what policies do you advocate states or progressive legislators in states push for? If we do get single payer passed, or if we do not?
Great. That's a really good question. I thought you were going to ask, why not state single payer? I'm opposed to state single payer. I don't think it works. There's a lot of functional problems in the way, structural problems in the way too. But this question is very good, and I'm happy to answer this one. I think this is going to sound like a cop-out, but I'll explain it in a second. I think the answer is whatever works. You fight for the thing you can win, you win it, then you fight for the next thing. Let's use Idaho as an example. Idaho's, if you don't live, does DC have expanded Medicaid? It does, right? Yeah. I presume so, but you never know. Medicaid expansion can have a lot of different forms, some of them bad. The Medicaid expansion movement in Idaho is cool because it kind of began from a school lean issue in Sandpoint, Idaho, this tourist town in North Idaho. The three friends who met there to kind of like say, we're gonna like pass this lean in our hometown, and that gave them the momentum to buy the camper van to go around the rest of the state. And that they knocked on thousands of doors to talk to thousands of people, built this infrastructure across the entire state of organizers mobilized under Reclaim Idaho, which is the Medicaid expansion initiative, and they won by a lot. They kicked ass. They won in most counties, and they won in urban and rural areas. And now, the cool thing is they get to call their shot. They get to say, we won big time over here, now we're going to go over here to win this. And they've decided to take on right to work in Idaho as their next big issue, which kicks ass because they probably will win. That's a good thing they can do there. It'll take a lot of work, but they can win it. In Texas, you've got the paid sick movement in Dallas, Austin, San Antonio. Not yet Houston, but hopefully one day Houston, from Houston. And there you've got a massive popular campaign that has succeeded. There have been some roadblocks, but not of their own accord. They just passed, and it just went into effect in Dallas, I think, last week. It'll go into effect in San Antonio at the end of the year. Austin, I forgot where they're at. I think it's coming into effect soon. But now they also give this big coalition that has never existed in this state, which can fight to win new things. In Maine, the Maine People's Alliance fought for and won a minimum wage increase in 2014, and they won. In 2016, do I have it? No, I have it backward. No, I had it right. In 2016, they took all the folks who were affected by the minimum wage increase and turned them out to get ballots to put Medicaid expansion on the ballot box. They got all their signatures in literally one day, election day. They hauled ass. And then they turned that out into a campaign to expand Medicaid, and they won again, massively at the ballot box. You win a thing where you can win it, and that helps you win more things going forward. So I don't know the lay of the land in DC. I don't want to pretend to. I hate to be that guy. If you guys already have Medicaid expansion, that sounds pretty cool. Locally, things like disarming the police, hiring social workers at the city level, having a crisis hotlines where they send social workers instead of cops to treat with mental health episodes. Those are all public health campaigns that are generally popular and that people like. Funding local clinics. Applying for if you want to get real wonky, get a group together to apply for a Medicaid grant to open a local clinic or help a clinic that currently exists get more funding. All these little things, like a Save Our Clinic kind of initiative. All these things and more have people like them. They're popular. I repeat myself, and they can be used to kind of coalesce into a larger and larger thing, like a snowball. Does that kind of answer your question?
Yeah, thank you.
Great. Thank you very much, Tim.